I will be showing you a few CT images. Mostly these are coronaries, and they're not as good as Professor Ayub's, but let's have an interactive sort of discussion. So this is my first case. 35 years old gentleman who was non-smoker, hypertensive, with history of postprandial chest pain. EDT was done, which was positive at high workload. And there were few, ECG changes also in the inferior leads and V4 and V5. So CT was advised and CT is done. So what is your comment? This is a VR image, and the other ones are, the curved multiplanar images showing the coronaries. These are labeled, you can see. तो इसमें यह है कि कॉर्नरीज इसकी बिल्कुल नॉर्मल हैं. सो दिस इज LAD, and this is circumflex, which is going between the in the left AV groove, and this is RCA, and this is an angiographic view, and this is a VR image. So you can see there is no evidence of occlusion. So in patients who have ETT done on a high workload, if the suspicion of cardiac disease is low, then you can go for this before going for invasive angiogram. जी सर, जी सर, यस. इंफीरियर लीड्स भी होती हैं, लेकिन V4 V5 में नहीं होती यूजुअली. तो जी जी, कैल्शियम स्कोर वाज 0. जी जी जी, yes. I will show you another case which has a calcium score 0 and has a critical disease. ये होता है इस तरह. You're right. So this is the second case. 40 years old man, smoker, BMI 26, chest pain off and on, and frequent emergency visits. ECG was within normal limit. Again, the ETT was positive. So we, before going for convasive angio, we did this CT angio. This is LAD, this is circumflex, and this is RCA. You can see this is a calcified plaque in proximal LAD, which was reported as mild to moderate stenosis. हाँ, मिड में भी है थोड़ा सा. So ischemia evaluation was done on the thallium scan, which was with no significant reversible ischemia was documented in the LAD territory. So medical management was decided, and so again, patient 27 years old, young man, hypertensive, non-smoker, presented with chest pain, blood pressure 150/90. Clinical examination was normal. ECG was unremarkable. जी जी जी. It was reported as mild to moderate, 30 to 50%. जी. That is why the ischemia evaluation was done, because patient had frequent emergency visits. जी, that is why the risk factor modification was advised. So again, you can see the coronary images. This is LAD, diagonal, circumflex, and RCA. So this is a VR image of the aorta. So you can see coronary artery disease is ruled out, as well as you can rule out coarctation and dissection in a CT image. 40 years old gentleman who had no cardiac risk factors, BMI 28, presented with chest pain. ECG was normal, referred for coronary artery disease evaluation. इस पे कोई comment करेंगे आप? So there is anomalous RCA from the left coronary cusp with the proximal interarterial course, and you can see there's a slit-like opening. इस पे ऐसे patients में भी आप फिर ischemia evaluation कर सकते हैं, but usually they do better than अगर आपकी राइट लेफ्ट कॉर्नरी हो तो उसमें फिर बाज़ का आपको रिवैस्कुलाइज करना पड़ता है सर्जिकली और परक्यूटेनियसली. So this was a patient with anomalous right coronary artery. 53 years old, female, no risk factors for coronary disease, atypical chest pain, frequent emergency visits, CT angio done. So what are your comments? This is the artery shown is circumflex. So this is again a curved view. This is aorta, LV, and this is LA. So it is arising from the right coronary cusp with the retroaortic course. This is usually considered to be a benign course. और वैसे उसके अंदर कोई obstruction नहीं है, and the artery is of good size. 36 years old gentleman, smoker, BMI 31, he was overweight, ECG normal, CT is done. And what is your take on this? Just the left coronary is shown. This is LAD and this is circumflex. This is a VR image. Any comment from anyone? नहीं, इसमें मेरे पास और इमेज नहीं है, इस वक्त सिर्फ यही है. So you can see there is a high origin and it is at the sinotubular junction and it is coming from the just above the right coronary cusp. ये exactly right coronary से right cusp से नहीं आ रहा है, it is at the tubular part of the aorta और the proximal course is interarterial. This course is intermittent. There is no, slit like this. The opening, the lumen is very good, but the rest of the coronary arteries, they are okay. So this is anomalous left main from the right coronary, just above the right coronary cusp, from the tubular part of the aorta. These are anomalous origins. You can rule out these anomalies on CT very well. So 35 years old man who had AVR 2 years back with good compliance with warfarin, presented with interval MI and was thrombolized. CT angio was done to define the coronary anatomy as patient was on warfarin, so the INR was 2.5. So we did the CT angio to define the coronary anatomy. So what are you seeing? This is LAD, and you can see there is a tight lesion in the proximal LAD. Probably this is the cause of the infarction. LV is dilated, and there is a clot in the LV apex. And this is a diastolic image. You can see the aortic valve prosthesis is adequately closing. And this is a systolic image. You can see the adequate excursion of the aortic valve prosthesis. So there was a normal function of the aortic valve prosthesis with a tight lesion in the proximal LAD and a clot in the LV apex. So what we can document on the CT, subtotal proximal occlusion of the LAD, interval akinesis, dilated LV with moderate function, adequate excursion of the aortic valve prosthesis and clot in LV apex. So we can have, quite a good information with a single, investigation. 49 years old man, mostly my cases are coronaries. 49 years old, BMI 25, smoker, had chest pain during routine evening walk, which was pressure-like associated with sweating. Vitally he was stable, ECG was normal. So patient had a very typical history of chest pain, but he denied to have an invasive coronary angiogram. So we did the CT angio. So this is a VR image, and this is the angiographic image, and you can see there's a tight lesion at the level of the bifurcating diagonal branch. So then he was advised conventional angio. This is the conventional angio image, which is almost as, identical to the CT image. So you can see this. This is a tight lesion. This is a bifurcating diagonal branch, and this is a post-PCI image. PCI was done then. So I would like to have your, this patient was referred for LED visualization. He had, coronary angiogram, and LED was not visualized during the conventional angio. So was referred for CT angio. So CT was done. You can see this subtotal osteoproximal occlusion of LED, and the very good size of the LED is visualized, which is up to the apex, which is this was not seen on the conventional angio. But would you like to have इसको cabbage के लिए refer करेंगे आप? Because the target vessel is very good. Single vessel disease. जी एनटीए वाले हैं भाई. पीसीआई भी चलो कर लेते हैं, लेकिन आप इसको कोई भी वेस्कुलराइजेशन के लिए, रीवेस्कुलराइजेशन के लिए आप उसको ऑप्ट करेंगे. अच्छा, excellent. Sir, you can see the NTA wall is almost thinned out up to the apex. From mid to apex, it is almost thinned out. It's gone. So before deciding for any revascularization strategy, you should have a viability, assessment. लेकिन viability में भी मेरा ख्याल है ये सारा infected था. So, जी? Maybe. But when the thickening is lost, so that is indirect evidence that the muscle is not viable. Hmm. Always better than the this. बिल्कुल. Okay. But the point that I wanted to stress upon was that. Hmm. But viability के लिए best modality is either PET or MRI. तो वो ठीक है. But the point that I wanted to stress upon was that with the CT image you can have a rough idea that what is your next strategy, because you can see this myocardium is almost lost. So this is another patient, diabetic hypertensive female, who had PCI of RCA 1 year back. She presented in the emergency with chest pain with ST depressions. Troponin was normal. She was advised MDCT for the stent patency. So we did the CT angio, and you can see the stent in the RCA is patent. But there is a new lesion in the left main, ostial left main. It's a tight lesion. So this was picked on the investigation which was done for the RCA. And then subsequently this stenting was done. This is a post-stenting CT image for the left main stem patency. Stent के लिए जो नहीं, it is if the size is more than 3 millimeter and it's proximal, and खास तौर पे जब आप लेफ्ट पेन की स्टेंटिंग करते हैं ना, उसकी सर्वेलेंस के लिए CT is advised. But she presented with our chest pain, which was thought to be atypical. So that is why we did the CT. इस पे कोई comment करेंगे जी? ये patient presenting with chest pain with emergency visits. Steven. So this is LAD with a significant bridging in the proximal LAD, and it's also horizontal deep down, and then it's coming out. This is the muscle, and you can see this VR image यहाँ पर ये disappear होगी. Again the angiographic view of the same patient. ये आप देख सकते हैं, ये V बना हुआ है, यहाँ से अंदर गई फिर बाहर आई. So again a patient with post PCI. जी, इसमें भी इस्कीमिया एवेल्यूएशन करके then you can go for surgery or maybe जी स्टेंट तो उस पर नहीं करेंगे ना, तो उसको तो डीप ब्रिज कर रहे हैं। हाँ जी जी वही। हाँ लेकिन उसमें भी आप यू कैन असेस द इस्कीमिया ऑन स्ट्रेस टेस्टिंग। जी जी।
इसमें तो ताहिर साहब ऐसा लगता है जैसे स्टेंट पूरे ही बंद है ऊपर से लेके नीचे तक
अब
पूरा
मैं आपको बताता हूँ। अच्छा दिस इज अगेन पेशेंट फॉर एलईडी विजुअलाइजेशन। इसका जब सीटी एंजियोग्राम किया तो उस पर उनको स्टेंट तो नज़र आ गया लेकिन आगे कुछ नज़र नहीं आया। स्टेंट के अंदर बस देयर इज अ माइल्ड आईएसआर इन बिटवीन, यहाँ पर है थोड़ा सा, यू कैन सी, ये मैंने उसी लेवल पे दिखाया है। ये देयर इज हाइपो अटेनुएशन इन द मिड कोर्स। ये मुझे एग्जैक्टली याद नहीं है। लेकिन ये है कि आप ये वी आर इमेज में देखें कि यहाँ पर ये आउटलेट पे इसकी एक्लूजन है, आउटलेट पे बंद है जी। लेकिन पोस्ट दैट दिस सेगमेंट इज ईजिली विजुअलाइज्ड। अच्छा खासा फ्लो जा रहा है। दिस इज अ गुड साइज्ड एलईडी, सो यू कैन द सर्जन विल बी वेरी कंफर्टेबल पुटिंग ऑन ग्राफ्ट ऑन
इसमें
इट।
जो आपको स्टेंट में कंट्रास्ट तो नजर नहीं आ रहा, तो स्टेंट में कंट्रास्ट नजर आने का ना आने का रीजन प्रोबेबली है कि डिस्टल ऑक्लूजन हुई हुई है तो वहाँ फ्लो ही नहीं है बेसिकली।
पॉसिबल है, लेकिन सर ये आप अगर देखें ना प्रॉक्सिमली देयर इज अ कंट्रास्ट इन बिटवीन, जहाँ पर है हाइपरटेंशन इन द मिडल एंड एट द आउटलेट।
नहीं वो तो दूसरी जगह से फील हो रही है, रेट्रोग्रेड फीलिंग हो रही होगी।
रेट्रोगेट फीलिंग हो रही है एलईडी की, बिल्कुल, जो कि उस पर नजर नहीं आई उनको एंजियो।
हाँ वो नहीं, सीटी पे आप नहीं बता सकते।
नहीं उस पर नहीं बता सकते, बट द प्रोबेबिलिटी
नजर नहीं आती।
probability of retrograde feeling can be there. Again a patient for LED visualization. इसके आप देखो ये स्टेंट के इनलेट पे टाइट लीजन है। There is a tight lesion at the inlet, but the post stent segment is not very clearly, मतलब बहुत अच्छा नहीं है, so not a good target for surgical revascularization. ये पेशेंट था जो कि हमने कल किया है। इसका जो कैल्शियम स्कोर was 0, 72 years old lady, effort angina, ECG was normal, calcium score was 0। ये 4 लिखा हुआ है लेकिन 0 था इसका calcium score. You can see this tight ostial lesion of the LAD.
अच्छा सर इसमें कैल्शियम स्कोर 0 लेकिन नीचे तो देखें आप,
नहीं वो 4 लिखा हुआ है
अच्छा
कैल्शियम स्कोर 0 है इसका।
ना उधर आप वेसल में
उसमें
देखिए
एक छोटा सा स्पॉट है,
राइट एरिया नजर आ रहा है आपको।
स्पॉट नजर आ रहा है, बट वो उस पर पिक नहीं हुआ। उस पर जो हम उसकी स्कोरिंग करते हैं ना उसमें नहीं पिक हुआ ये, लेकिन इसमें नजर आ रहा है।
जी जी
इस पे भी अब ये मतलब चलो 4 भी है तो बहुत थोड़ा कैल्शियम स्कोर है, मतलब प्रोबेबिलिटी ऑफ डिजीज वेरी वेरी लो, बट वहाँ बिल्कुल नहीं है। इट्स सॉफ्ट प्लाक, इट्स अ सॉफ्ट प्लाक एंड इट्स अ टाइट ऑस्टियल एलईडी लीजन। टाइट ऑस्टियल वेरी रेयर है। इट इज 72 एज और 0 कैल्शियम एंड देन यू हैव दिस डिजीज। ये पेशेंट आज ही किया हमने। इट वाज एन इम्पॉर्टेंट प्रिजनर presented to our ER. Important. So this was he presented with chest pain. Troponin was normal. So we did the CT today in the morning. So there are stents in the LAD and RCA. This is circumflex. इसका stent extend कर रहा है from the left main to the almost proximal LAD to mid LAD तक. But this is मतलब ये आप देख सकते हैं, it's patent stent with no hypoattenuation, no occlusion. And this is RCA proximal distal stent, but in between you can have this moderate lesion post stent in the mid RCA. और ये इसकी circumflex है जिसका ostium probably इन्होंने dilate किया होगा, and this is small size circumflex which is also okay. So post PCI surveillance you can do on CT angio. ये शॉर्ट एक्सिस में मैंने दिखाया कि वो जिस लेवल पे ये शर्ट्स हैं मुझे नज़र आ रहे हैं जी, और अच्छा खुला हुआ है और मतलब ठीक है। वही बात है, अगर स्टेंट का साइज 2.75 से ऊपर है तो इट इज़ ऑलवेज गुड टू डू द CT एंजियो। इट्स नॉन इन्वेसिव एंड अच्छा, दिस इज़ एन इंटरेस्टिंग पेशेंट, 75 years old gentleman, hypertensive, non-smoker, non-diabetic, BMI 28, presented with
डॉक्टर
severe
नवीद
chest pain.
डॉक्टर नवीद, वो जो पिछला केस अभी हमने देखा है,
जी जी,
मैं
ये वाला?
डॉक्टर टीपू से बात कर रहा था कि जब स्टेंट देखते हैं तो इसमें अभी तो आपने एनाटमी देखी है, हमें फिजियोलॉजी का नहीं पता, सो एफएफआर वुड बी इम्पॉर्टेंट।
But
और
इसमें
उसके
FFR
लिए
कौन?
मैं एक बात जो करना चाहता हूँ वो ये है कि जैसे मैं कैरोटिड में स्टेंट देखता हूँ, अच्छा उसका टेक्निकली स्पीकिंग हम एफएफआर कर लेते हैं, हम जब पल्स वेव डॉपलर करते हैं बिफोर द स्टेंट, इन द स्टेंट एंड पोस्ट स्टेंट, तो उसके पैरामीटर्स नॉर्मल से फ़र्क होते हैं, उनको रीड करना भी आना चाहिए। स्टेंट की वजह से वो थोड़ी सी वैल्यूज़ ज़्यादा आती हैं या कम होती हैं, दिस इज़ फिजिबल। हम कैरोटिड्स में तो करते हैं, स्टेंट पड़े होते हैं उनको देख लेते हैं, तो यहाँ पे भी एफएफआर जब कर लेंगे तो हमें ज़्यादा इन्फॉर्मेशन आएगी।
But you have history, you have ECG, you know, सारे पैरामीटर्स, you have top levels, उसके मुताबिक आपने उसको इंटरप्रेट करना होता है. तो I mean this is a low probability of the disease in the stents. But there is a disease progression. जी. So he was 75 years old gentleman, known hypertensive, non-smoker, non-diabetic, BMI 28, severe chest pain, anteriorly and interscapular region on the back of 6 to 8 hours duration, associated with sweating and shortness of breath. Pulse was 80 per minute regular, blood pressure was 220 by 120 on the right arm. S1, S2 was audible, chest vesicular breathing. This is the chest x-ray. ECG was normal. So troponin was also normal, all other labs was okay. Transthoracic echo showed no wall motion abnormality, good LV function, normal root, normal valves. So this is the CT of that patient. So what are your comments? This is a coronal view and this is an axial view. Diastolic flavor. जी जी. Left ventricular hypertrophy, very good, because this is a diastolic जी hypertensive patient है जी, बिल्कुल borderline you can say. और दूसरा ये कि ये यहाँ पर इसका valve is perfectly normal, there is just a speck of calcium, बाकी valve is perfectly normal, the root is mildly dilated, descending aorta भी, और important no is there is no dissection and the visualized segment, no dissection seen. So there was a eccentric thickening just above, below the aortic arch in the ascending aorta. You can see this. This was eccentric thickening with hypoattenuation in between. This is a delayed image of that patient. जी 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 वही मैं बताने लगा. So this was a case of basically this is a delayed image. You can see now very well that hypoattenuated eccentric thickening of the aortic valve. This is again a coronal view और उसकी thickness भी मैंने बताई है. So coronaries were normal. This is LAD, diagonal, circumflex, RCA. But there is a moderate lesion at the ostium of the PDA. बाकी इसकी right coronary artery was perfectly normal. So he presented with severe chest pain, no dissection, but there is an intramural hematoma. So his diagnosis was intramural hematoma, which is a dissection without flap. So what else we could document? Moderate single vessel disease, normal LV function, no PE, normal aortic valve, LVH. This is again stent 7G. उसके डबल ओब्लिक में हम करते हैं, वो शॉर्ट एक्सिस में होता है, बस थोड़े बस ठीक थोड़ा रहेगा बस थोड़ा रहेगा. मैं आई विल रश. This is again ISR in the SVG2 obtuse marginal branch. You can see this hypoattenuation उसी लेवल में दिखाया है उसको. इसको फिर छोड़ दें. Dissection. This is pulmonary embolism. This is a case of aortic dissection type A with coarctation of aorta. Root is dilated and the horizontal line, this is pseudo dissection. ये artifacts हैं. दिस इस वक्त तो मैं ये नहीं कर सकता, बट रूट वाज डायलेटेड. दिस इज द डाइसेक्शन फ्लैप. दिस इज द डाइसेक्शन फ्लैप. Again a patient of dissection. This was dissection with the pericardial fusion. You can see this dissection flap. Dissection flap. Again a case of intramural hematoma, eccentric thickening of the aortic arch. और ये भी चेस्ट पेन के साथ प्रेजेंट किया था और हमने उसको फिर वही. This is you can see the flap and the CT cine angio. This is a flap which is interfering with the normal function of the aortic valve. So patient will be requiring a Bentall. जी. Because of that flap, the aortic valve is not functioning. No. जी बिल्कुल. नहीं, हमने मतलब सीटी इसलिए किया था कि उसकी ज़ाहिर कॉर्डी एनाटमी भी डिफाइन करनी होती है, उसकी एक्सटेंट हमने दिखाया. अगेन अ केस ऑफ डाइसेक्शन विद bicuspid aortic valve. This is a bicuspid aortic valve. Dissection flap which is obstructing the left main. So this is extending into descending thoracic aorta. This is a 45 years old female, no risk factor, presented with atypical chest pain. CT coronaries were normal, but you can see this asymmetrical hypertrophy in the apical segments. This was a case of apical hypertrophic cardiomyopathy. ये पेशेंट यंग प्रेजेंटेड विद फीवर, echo showed severe AR. इस पे आई वुड लाइक अगर आप इस पे कोई कमेंट करें थोड़ा सा.
एब्सिस है और एन्यूरिज्म है.
सो और इसके अलावा कुछ
AFIC दी ना, उसके बाद 6.5 to 7 AGM के साथ 10 थे, 7-10 देते इन्होंने.
इसमें कुछ
जी exactly sir. This is a subaortic membrane that was the cause of aortic valve dysfunction, and she had this this is a vegetation scene, and this is a diastolic frame. You can see the vegetation coming into the LV, and this is systolic frame. The vegetation has gone up. So this is a subaortic membrane. Coronary ectasia, the corneal disease. आगे चलते हैं. Case of pericardial fusion. You can see this abnormal septal motion in this patient of large pericardial fusion. Pericardial fusion with LV clot. इसको छोड़ देते हैं. So these are few interactive. Cardiac CT is least likely to predict which of the following: valve perforation, vegetation size, vegetation location, perivalve abscess, vegetation mobility. The correct answer is perforation. Perforation you cannot exactly see, but size, location, abscess formation, vegetation mobility you can easily assess on the CT image. So again a bileaflet valve at the so this is a bileaflet valve which is not functioning properly, but this is the diastolic frame. You can see this disc moving, and this disc is stuck in the closing position. This is a closing of that valve. ये opening इसकी एक disc की हो रही है, दूसरी की नहीं हो रही. So there's a stuck disc. इसको छोड़ देते हैं. So these days CT is done for a structural heart disease. So what procedure is being planned for this patient? Mitral clip, Lele occlusion, TAVI, left TAVI, because you see this annular plane से हमने उसका लेफ्ट मेन का मेजरमेंट की है, RC की मेजर की है, और ये annular diameter. So this is the last one. So what is the image type? Type of the prosthetic valve, site of the prosthetic valve, and diagnosis. Site बता दें कौन सी है ये. Why do you say so? आपने कहा एओटिक. नहीं, साइज का कोई मसला नहीं है. साइज का कोई मसला नहीं है. मैं कहता हूँ माइटल वेल है, तो आप कैसे कहते हैं ये दिस इज अ VR इमेज. ये प्लेन स्कैन किया था, उसमें सिर्फ ये वेल्व दिखाया है, बिकॉज यू कैन सी देयर इज नो कैविटी विजिबल. कंट्रास्ट किसी में भी नहीं है. वी आर इमेज ऑफ ए प्रोस्थेटिक वैल्व. तो टाइप तो हो गया प्रोस्थेटिक वैल्व, ठीक है जी. साइट इज जी मुश्किल नहीं है, बिल्कुल आसान है. नहीं ये इसका प्लेन स्कैन किया था हमने, बिल्कुल आसान है. यू सी ये आप यहाँ पे 30% नज़र आ रही है आपको. दिस इज अ सिस्टोलिक फेज एंड दिस इज अ डायस्टोलिक फेज. सो डायस्टली में ये बंद हो रहा है और सिस्टली में ये खुल रहा है. सो दिस इज एओर्टिक वाल्व प्रोस्थेसिस. और इसमें भी एक डिस्क इसकी मूव कर रही है और एक इसकी स्टक हुई हुई है. सो दिस इज अ एओर्टिक वाल्व प्रोस्थेसिस. So the clue was here 30% and 80%. Thank you.